Now let's move to the treatment of the hepatocellular carcinoma, and in this section we will mainly talk about the treatment of the stage 1 and 2 of the hepatocellular carcinoma. And the treatment options for stage 1 and 2, which we will discuss, will be the surgical, excision and local ablation strategies, liver transplantation, and the adjuvant therapy for stage 1 and 2. The tumor node and metastasis stage 1 and 2 hepatocellular carcinoma. T and M is the tumor node and metastasis. Surgical resection is done. There is local ablation, thermal radio frequency, microwave ablation, which is MWA, microwave ablation, local injection therapies, and then orthotopic liver transplant, OLTX, orthotopic liver transplant. So here you can see this is the picture of the liver and then the donor liver and the liver transplant recipient. So the liver is transplanted from the donor to the recipient, and then there is surgical resection, local ablation, which can be thermal by the microwave ablation also, and local injection therapies are performed. Treatment is if the hepatocellular carcinoma is diagnosed, then the different strategies are used. If the patient is ablation candidate, then we should do resection and RFA, non-cirrhotic, Child's A, single lesion, no metastasis. So these are the patients who are candidate for ablation. Like they are non-cirrhotic, they don't have cirrhosis, they are Child-Pugh A classified, there is only single lesion present and there is no metastasis. These patients are treated with the ablation. The other type is the transplant candidate who needs the liver transplantation. The evaluation is one lesion which is less than 5 centimeter, and they have 3 lesions of all less than 3 centimeter. Child is A, B, C, and then alpha fetoprotein level is more than 1000 nanogram ml, no gross vascular invasion. So if these features are present, these patients are treated by liver transplantation, and the transplantation can be the living donor donor or the cadaver donor, and then we have a wait list for that. If there is yes, we do have a cadaver donor wait list, then we do a neoadjuvant bridge therapy, RFA, TACE, and 90 yttrium, and then we do the transplant. During the wait time we should give the therapy. Then the third category is patients who are not suitable for surgery. They have a medical evaluation should be done, comorbid factors, 4 lesions, and there is vascular invasion and metastasis is present. These are the patients who are not the candidate for the surgery. They should be treated by the PEI, RFA, and microwave ablation and different methods. They have single lesion less than 5 centimeter, Child's A, B. Then we also use TACE 90 yttrium. New agent trial also can be used, and then the new agent used is the sorafenib, which is new agent used for the clinical trials. And similarly, we can try sorafenib, and which is the palliative care is also given. So the treatment of hepatocellular carcinoma, we categorize into 3 levels. In the first, we can treat by ablation. Minor, it's a early stage. Then in the second, patients who require the transplantation can be from the live donor or it can be from the cadaver, and during the waiting time we need to treat to avoid the progression and then the transplant. Then in the third category, there are patients whose tumor or malignancy is widespread, is infiltrative, and there is vascular invasion is present. These are not the candidates for the ablation or the surgery, and they should be treated by different non-surgical treatment options that are available to, and they need the palliative care. Treatment options for hepatocellular carcinoma, these are all the treatment options. We already talked, let's go over them in detail. We need the resection, then the liver transplantation is done in the surgery. Then we have local ablative therapy, ablation therapy. We have radio frequency aberration, RFA. I mentioned this again and again. So RFA is your radio frequency ablation. MWA is microwave ablation. Cryosurgery, and then PEI is percutaneous ethanol injection. So this is another treatment, surgery. Then we have ablation therapies in which we have RFA, radio frequency ablation, microwave ablation, cryosurgery, and percutaneous ethanol injection, PEI. Then we have some regional therapies, hepatic artery transcatheter treatment, in which we have transarterial chemotherapy, transarterial embolization, transarterial chemoembolization, transarterial drug-eluting beads, transarterial radiotherapies with 90 yttrium microspheres and 131 iodine ethiodol. So, and proton beam radiation. So all these are the hepatic artery transcatheter treatments. Then we have conformal external beam radiation and intensity modulation radiation therapy, which includes systemic therapies, molecularly targeted therapies like the drugs, which is the new trial sorafenib, chemotherapy, immunotherapy, and hormonal therapy plus growth control. Then we have some supportive therapies for the patient who have no very poor prognosis and when other treatment options are not used. So in detail in this chart, we talked about the different treatment options and what different abbreviation they stand for and which are used for the hepatocellular carcinoma. Surgical excision, which is a preoperative portal vein occlusion. Ascites, varicose bleeding, OLTX. Laparoscopic approach, RFA, radiofrequency ablation, microwave ablation, and then we have percutaneous ethanol injection, transcatheter arterial chemoembolization, which is TACE, stands for with RFA. So TACE is transcatheter arterial chemoembolization. So this is the surgical excision. Local ablation strategies, we have RFA percutaneously with CT or ultrasound guidance, laparoscopy. Local injection therapy, ethanol, direct destruction of cancer cells, multiple injections every 3. So these are also different treatment options in which we already talked. We have surgical, we have local ablation, and the local injection therapies. Liver transplantation, OLTX. For patients with a single lesion that is less than 5 centimeter, less than 3 nodules, each less than 3 centimeter, that's Milan criteria, high tumor recurrence rate, RFA TACE, hepatic arterial 90 yttrium radioembolization. So these are the liver transplantation is used for patients who have single lesion of less than or equal to 5 centimeter or 3 nodules each of less than 3 centimeter, or those who have high recurrence rate of the tumor. Post-local ablative therapy is done after the transplantation. If you see, this is the gallbladder that is removed, and then we have inferior vena cava. This is the portal vein, hepatic artery. This is the diseased liver that is removed, and this is the donor liver which is transplanted. Current directions, expanded criteria beyond Milan criteria, downstaging of hepatocellular carcinoma by medical therapy, TACE, treatment before transplantation, alpha fetoprotein levels more than 1000 nanogram. There is high transplantation recurrence. Use of salvage transplantation, OLTX. So these are the current directions for hepatocellular carcinoma. Expanded criteria beyond Milan criteria. We already talked one single less than 5 and then 3 lesions less than 3 centimeter. That's the criteria. Downstaging of ACC by medical therapy. If with the medical therapy the staging of the hepatocellular carcinoma is getting down, then treatment before the transplantation should be done. Alpha fetoprotein levels more than 1000, then the high there is recurrence for the OLTX. Adjuvant therapy is the chemotherapy. TACE and neoadjuvant 131I ethiodol, antiviral therapy, nucleoside analogs in hepatitis B virus-based hepatocellular carcinoma, and PEG interferon plus ribavirin. So all these are different adjuvant therapies used for hepatocellular carcinoma. We can use the chemotherapy and chemical embolization, and neoadjuvant 131I ethiodol. Antiviral drugs are also used. It's for the hepatitis and for the hepatocellular carcinoma. And then we have PEG interferon plus ribavirin is used. Trials with or without sorafenib, which is the new trial drug for the treatment of hepatocellular carcinoma. This was all about the treatment of stage 1 and stage 2. Thank you for watching sqadia.com.